Thank you, Dr. Park. Ladies and gentlemen, our ability to regenerate bone around the implant is quite important in implant dentistry. Of course, plan management or implantation as well as suturing technique are important. I have learned from great masters like this picture, and so various bone regeneration techniques. As you see above, I've tried ridge augmentation and applied many kinds of ridge augmentation techniques in extreme cases like this. Also, I have attained very good outcomes. This made me proud of myself. Yes, sometimes we meet some difficult situations for the treatment of implant in daily practice. Among them, especially there is a low alveolar ridge. In other words, cases necessary for vertical augmentation. Another is thin ridge. These cases needed horizontal ridge augmentation for adequate implant prosthesis. And another is sinus grafting. So thin ridge and sinus grafting cases will be presented by my friend and smart guy and inventor of Mila and Mika kit. Samuel Lee will present that. Let you review one case in regard to low alveolar ridge case. In the past, before my meeting Eisen membrane, this patient needed vertical and sinus grafting or horizontal ridge augmentation for adequate implant prosthesis. So I waited the soft tissue healing for 2 months after extraction and have done sinus grafting and vertical augmentation procedures using the Gore-Tex membrane for bone regeneration around the implant. Yeah. The soft tissue healing was good. You can see the defect morphology. And then the sinus grafting was done. And the defect was applied by the mixture of xenograft and the allograft materials. And the Gore-Tex membrane is applied on that. The curb screw was fixed, and suturing was done, and soft tissue healing, uneventful. So just after the surgery, the panoramic view like this. After 8 months, I found the regenerative bone around the defect. The defect was changed by this. But after 6 months, I have not finished yet. So I have been waiting the next step. These days, I use the new concepts of like this, the low ridges. After extraction, soft tissue healing. So I do the sinus grafting and the vertical augmentation and the implantation all together. Before defect like this, after that, well done like this. What is the answer for that? Okay, then, as you see above, is only using non-reusable membrane enough in bone regeneration around the implant? Yes, I agree with that. This may be enough, but I don't entirely agree with that. Then I have two questions. If you make bone regenerate around the implant, that first, is it enough? Is it everlasting? How much bone quantity around the implant? As you see, this is uniform tissue around the implant with the Gore-Tex membrane. It's a very gorgeous outcome, as you see. So, unfortunately, in this case, we could find a viral rejection of the regenerated hard tissue around the implant after 2.5 years of loading. Well, if so, what shade of bone do we need to make around the implant? From now on, let me introduce you to my concepts about the bone around implants. Let's take a simple quiz. As you all know the answer. What are the differences between natural tooth and implant? Yes, first, periodontal ligament and cementum. The second, collagen fiber, its direction and density. And the third, that is blood supply. And so, for this reason, we make the more bone or soft tissue around the implant than natural teeth. Here are 3 papers about these questions. Let's review them in brief. The first, Dr. Nozawa group suggested the thickness of the gingiva would be stable when it is 1.5 times thicker than the height of marginal gingiva. The second, and Dr. Spray concluded from his study when the buccal bone width of the implant was more than 2 millimeters, the failure rate decreased rapidly. This means that we have to make at least 2 millimeters of the buccal bone width around the implant for long-term success. Finally, Dr. Grunder suggested the buccal bone width of the implant was more than 2 millimeters. Preferably 4 millimeters. Okay, let's assume that there is a bone defect as you see above. In summary of all these articles, we need to obtain at least 2 millimeters of buccal bone thickness for maintaining stable hard and soft tissue around the implant. Watch the shape of the bone. Frequently, it has problems using non-supporting membrane around the defect. Let's review one case. The patient had been fully installed the implant in the edentulate maxilla, but the implant site had a dehiscent defect on the buccal wall. I didn't intend to use the different type of membrane on the same alveolar defect, but I used the non-supporting membrane on a right maxilla and the titanium reinforced membrane on the left maxilla. Oh, sorry. What happened? When I re-entered the site for removing the non-leasable membrane, I am confused the result, the different result of right and left. As you see, the resorption rate is high on the right maxilla rather than the left. Why does it show this? Although we commonly use the graft barriers membrane or graft materials, it doesn't have any ability to maintain space in the right maxilla. In other words, the result of not using non-supporting membrane is not predictable. What does Dr. Grunder do in like this situation? As you see above, he grafted a large amount of bone material like this, forming a shape close to right angle. Then, to acquire sufficient space for bone rejuvenation around the implant, he used titanium reinforced Gore-Tex membrane. The result was good, as you see. Well, there is another factor to consider, which is the vertical direction of a remodeling shrinkage in the augmented bone. So, membrane. What should it be for ideal rejuvenation? As I mentioned, to avoid the common mistake of non-supporting membrane, the vertical space maintained must be at least 1 millimeter. Whatever membrane used, there will be from 0.5 to 1 millimeter remodeling shrinkage. So, this remodeling shrinkage should be considered too. Considering this resorption or remodeling shrinkage, the horizontal extension needed to be more than 2 millimeters of the buccal bone width. And the blunt angle of close to 100-degree blunt angle will be helpful to avoid soft tissue irritation. So, these are all important factors included in the Eisen membrane system. A little remodeling shrinkage can still be found, but because the Eisen membrane system was designed to consider this remodeling shrinkage by overcorrection 1 millimeter or 0.5 millimeter, the amount of the regenerative bone we want is protected. So, yeah, the shape of regenerative bone should be close to right angle, about 100-degree blunt angle. So let's watch the one simple video for a simple application of Eisen membrane on the right. First, premolar defect of maxilla. The patient have a simple buccal adjacent defect. So after incision and level elevation, you can see the defect morphology of that. And an enriched fixture was installed with good initial stability. After that, corresponding to interproximal bone, we can choose the plate abutment height. So after that, around defect, we can graft bone graft materials. In this case, I used a xenografting material. Depending on defect type, I can choose the ISA membrane. In this case, I use the type A. Normal suture was done. After 3 months, we could find the result of the regenerated bone around the implant by ISA membrane. You can see the non-reusable membrane, very difficult, like Gore-Tex or Cytoflux, but the ISA membrane, removing the ISA membrane is very easy because of the plate abutment. You can see the close to right angle, the regenerative bone around the implant. Yes. Oops. Let's assume that there is a bone defect like this. Type A ISA membrane can cover the dehiscence or fenestration defect like this. So defect is changed and more larger, more bigger than the type A. So type B can cover that side. And type C can cover the lingual defect. So palatal or lingual component is concluded or designed for type C ISA membrane. In this case, not single case, but there is the multiple case in anterior maxilla. So I scheduled the treatment. The 21, 23, 25 site were installed by the energy fixture, and after that, you can see the sequence. For soft tissue healing, I waited 1.5 months. So incision and plate elevation was done. You can see the defect morphology. And the energy fixture was installed with good initial stability. And then the plate abutment was connected. After that, the xenograft, the mixture of xenograft or allograft materials were grafted around the defect, and ISA membrane was connected. Then, in this case, we can use the collagen membrane with the ISA membrane. The radiographs was good. So soft tissue healing was not eventful. So after 6 months, I removed the IJ membrane by only small hole like this, by characteristic of flat abutment. So when I remove the IJ membrane, you only do that. Unscrewing the flat abutment, IJ membrane automatically detached from that side. These automatically simple procedures of removing the IJ membrane provide the protection for the regenerative bone by minimally invasive trauma on that side. Therefore, the IJ membrane system makes the second surgery of non-resorbable membrane so easy, and the regenerative bone around the implant protect from frequent exposure. After second surgery, I checked the radiograph state of the regenerative bone around implant. CT scans gave a surprising result. Can you see this? Yes, that is neocortex. Also, thanks to solid scaffolding of the IJ membrane on both mesial and distal area, we could find good result between the IJ membrane as we expected in covering site with collagen membrane. So, as you know, when we use the Gore-Tex membrane, Gore-Tex is a two-dimensional morphology. So when we applicate that in a curvature site, very difficult. But in case of IJ membrane, you can use the collagen membrane with IJ membrane. We can cover the curvature or single or multiple case. Another case is there is two-wall defect. The patient of 56 years female had missing tooth of first premolar on right maxilla. May this year, a magazine symposium has been held in Seoul, Korea about 4 months ago. I've performed live implant surgery just for 15 minutes using the IJ membrane, the AltoGate system. Defect morphology was so complicated with the buccal and palatal defect on the CT scans. This photo shows you the healing state of soft tissue 1 week after extraction. I did the virtual surgery like this using AltoGate program. So I prepared the Alto stent and the type of IJ membrane selected for defect morphology. From now on, let me show you live surgery, but edited for a limiting time on this presentation. Plan management, like releasing incision and the thinning of granular tissue, was done before surgery because of a limiting time of 15 minutes. You can see the Alto stent after gradually drilling The reason why I use the alto stand, because of a limiting time of 15 minutes, I want to locate the platform or fixture in accurate site where I want. I selected the C2 type as a membrane because of a positive. Can you hear me? I like vertical matrix suture method on tension-bearing side. The suturing was done after 4 months. Soft tissue healing was not eventful. As I mentioned before, basically, we don't need to use a large flap surgery for removing ISA membrane. In this case, I want to identify state of regenerative bone around defect, so I open the flap with a large margin. Now you can see the closed right angle buccal or palatal side, like this. But you can see the white tissue, reactive connective tissue. But according to many articles and my experiences, we don't need to remove the whitest connective tissue under non-resorable membrane and the NISM. If the flaps were repositioned, the connective tissue would be attached around the periosteum. Yeah. The palatal side was modeled by the shape of a Grunder angle, close to right angle. Pre-op CT scans, looking like this. Post-op CT scans. You can also the neocortex on palatal side, just for 4 months. Pre-op panoramic view, post-op, looking like this. Yes. Now, the last case, I show you the severe alveolar defect have vertically, horizontally, and anterior maxilla. Defect morphology looking like this. I scheduled the site of implantation was 11, 21, 23 site. You can see the horizontal and vertical defect like this. Pre-op CT scans revealed that severity of the defect. Before surgery, I have performed the virtual surgery via AltoGate program. So 11, 21, 23. You can see the implant was positioned protruding situation. AltoGate. Incision and flap elevation was done, and I analyzed the defect morphology corresponding to the AltoGate virtual surgery. So I installed by AltoStent, using AltoStent by AltoGate program, because of accurate position of platform and the fixture. After that, considering the vertical direction of remodeling shrinkage, I selected the flat abutment height. In this case, 2.5 height of flat abutment was selected for that. You can see the protruding state around the defect 1121. Genograft or allograft mixture was grafted around defect about 4 or 5 cc. Then I connected the ISA membrane on the flat abutment. After that, I fixed the ISA membrane with a curved screw. On defect, depending on the defect, various defect, we can choose the type of ISA membrane. As I mentioned before, in this, like this curvature situation, we can use the combination of collagen membrane in uncovered site of ISA membrane. After suturing, 1 week after the surgery, the soft tissue healing site was good. After more 1 week, I will do the stitch out. But the result is not here. After that, next time, I will show you the result. Yes, first of it, CT scans reveal the regenerate situation around implant or defect. You can see this photo show you the result was the sham surgery. Sham surgery now with the Altigate program. So a post-op panoramic view. Yeah, you can see the result. So in daily practice, we met the various defects: anterior low, anterior thin, the posterior low, and posterior thin. And mandibular side, we meet the mandibular low, mandibular thin. In this side, we can cover the defect like this with Eisen. But you can also consider the situation in mandibular posterior side. How about the lichess flip? As I mentioned before, lichess flip cases by Samuel Lee will be presented after me. Yeah. Thank you very much.
Thank you, Dr. Kim.